Good afternoon, everyone. Welcome to today's webinar hosted by Patagonia Health. Today's webinar topic is on rural public health financing and resource allocation. If you aren't familiar with the GoToWebinar platform, take a look at the control panel at the bottom of your screen. Here, you can configure your audio settings, send chat messages, and ask questions. As a background to our speaker, Michael Meat serves as Director of the East Tennessee State University Center for Rural Health and Research, located in the Appalachian Highlands of Northeast Tennessee, and as Deputy Director for ETSU's HRSA-funded Federal or Rural Health Research Center. Michael currently leads studies focused on the evaluation of rural health programs, public health financing, opioid misuse, and emergency preparedness, among others. He is a longtime rural public health researcher and evaluator, having worked on federal, state, and local projects for over 20 years. Michael also serves as a co-investigator for the Center of Workforce Research and Public Health. He serves on the editorial boards for the Journal of Public Health Management and Practice, the Journal of Appalachian Health, Journal of Rural Mental Health, and Public Health Reports, and is a governing counselor for the American Public Health Association. In 2019, Michael was named the National Rural Health Association's Outstanding Researcher. We are so excited to have you, Michael. Without further ado, I'm going to pass it over to you.
All right, thank you very much. Let me, if you can pull down that screen, I'll share mine here.
Okay. There we go.
There we go. All right. All right. You seeing the slides here?
Yeah, looks great.
Perfect. All right. So this is where I like to begin. And I really appreciate the opportunity to have this discussion. So I always begin when I talk about public health financing with this quote. Funds have been so inadequate and so uncertain as to amount that long-term planning has not been practicable. The need for a substantial, consistent, long-term program of federal support for the rural health service is recognized by practically all authorities in the public health field. It's a really nice, strong statement. And here's the punchline. That statement is from a public health service report in 1936. So this is not a new topic. This is something that we have been discussing and struggling with really for going on 90 years now. So here's what I want to talk about. So what I want to do is I want to talk really mostly about how rural health resources are distributed. So I want to talk about local health department funding and service delivery by geography. So we're going to look at rural and urban health departments and how they're funded. Then I want to talk really broadly about how money flows, particularly through block grants, which is one of the major ways that federal dollars make their ways to state and then from states down to communities. And then I'm going to talk about area level vulnerability indices. So you are probably more familiar with these as referenced as tools like the Social Vulnerability Index, which is CDC's version. But we've identified well over 50 of these. And I want to talk about how these are being used and some of the challenges that these indices have. And then I want to end by talking about really practical tools for finding data in your community. So essentially, what we're going to do is talk about some of the challenges in getting money to rural communities. And then we're going to end with accessing data so you can make the best case available to bring money to your communities. So again, beginning with health departments and how they're funded, we know that health departments are funded by various types of grants, categorical grants. These are grants that come for very specific purposes. A lot of health departments have been seeking and increasing their clinical services and reimbursement that they are able to attain through clinical services. Block grants I mentioned already, and we're going to talk about that more. And then at their core, there's a lot of tax revenue that comes in, particularly local tax revenue, that supports local public health services. And then each of these funding types really varies by level. So there's local funding to support local public health, state funding to support local public health, and of course, federal funding to support local public health. What we know is that federal funding in itself is a very significant proportion of health department revenue. We did a study, it's been over 10 years ago now, but what we found was that the majority of health department revenue is actually federal dollars, either direct federal or federal dollars that flow through states, really 57 to 75% of their total revenue. At that time, we had seen that third-party reimbursement was growing as a share of public health funding, and I think that has continued. And then we saw that there were smaller percentages from state sources, fees, fines, and other sources. I think one of the really important points, and I think this is becoming all the more important as we look through the current federal budget discussions, are that the health departments across the country, their largest percentage of federal revenue is not from CDC, which I think a lot of people in public health assume. It's actually from USDA. So when we talk about SNAP cuts, when we talk about WIC programs, that's really what is making up the largest percentage of federal revenue for health departments. And those cuts are going to be felt very, very hard, in addition to the cuts from CDC and others. So the other things we know are that federal expenditures for public health tend to ebb and flow, often based on emerging needs. So we in public health tend to ride one crisis to the next. So we had Zika, which led to a lot of money. We had Ebola, which led to a lot of money. H1N1 led to a lot of money. And then most recently, COVID-19 led to a lot of money. So as these different types of issues tend to ebb, the funding tends to go down. As we see a new issue emerge, funding goes up. It's not a great way to fund a consistent, sustainable public health system, but that's how our system has traditionally been funded. As I mentioned, health department revenues tend to be categorical in nature. That's a problem because it may not correspond to local needs. So essentially, we are identifying federal priorities, allocating money by federal priorities, and not being particularly mindful of what the needs are at the community level. And then one of the things that I think is also really important is to recognize that all funding for public health has decreased. Federal funding has decreased, but that federal funding has actually decreased at a slower pace than the state and local declines. And what that means is that proportionally, health departments have become more reliant on federal dollars, even as total dollars have gone down. And again, as we look at potential budget cuts, that could get worse across the board. So I'm going to show you this slide a few times, different versions of this slide. But essentially, this is data that comes from NACCHO. This is a little bit out of date. The newer data that are available do show these same trends. But over time, the rural sample in the NACCHO profile has gone down. So I tend to like to use the older data just because we have a more robust rural sample. But what we have seen over time, and we've done this several times now, is that rural health departments have less local revenues. That tends to be that tax revenue. They're proportionally more reliant on state and federal flow-through funds. Those tend to be those categorical grants. And rural health departments are more reliant on clinical revenues, both Medicare and Medicaid and private pay. So what does this mean as we think about some of the things that are driving change in public health? Well, as we see state and federal budget cuts, rural health departments, as I mentioned, are more reliant on those state and federal dollars and have less available local dollars. So it's harder to have a fallback plan if you lose your state and federal dollars. In terms of the reliance on categorical funding, I've talked about that a little bit. But again, they're more proportionally reliant on categorical funding. That means that local health departments and rural communities have less local flexible dollars to address local needs. And then finally, the changing reimbursement environment. This really cuts both ways. So urban health departments have been able to stop doing a lot of the clinical services because there are other providers in the community who have been able to take on that role. they're able to do that because they have more local revenues. Meanwhile, those rural health departments have really had to lean in to their clinical service provision, and they rely heavily on those clinical revenues. They use them both as touch points to help connect people to other public health services, but they also use that as a revenue source to support basic core public health services. They're really critical. And again, as we talk about potential Medicaid cuts, that has very, very significant implications for those rural health departments. And then just showing this another way, this is data from NACCHO's Forces of Change survey. Actually, I'm sorry, this comes from their profile of local health departments as well. But what we see is that rural health departments are more likely to provide those direct clinical services, what we just showed in terms of the revenue. And then the urban health departments are more likely to be providing more population-based services. So again, we see this split. And I think it's really tough when we think about our public health system around the country, because essentially we have health departments headed in very different directions, providing different types of services based on whether they're urban and rural. And it makes it really hard for us as public health professionals to have a unified message when our public health departments are really providing very different services based on the geography. That's not entirely a bad thing. I do think that those health departments are for the most part very responsive to local needs. In rural communities where you lack healthcare providers, taking on that clinical role meets a local community need that may not be needed in an urban area. But again, it's kind of hard to advocate for public health when we have health departments doing vastly different things. So I'm going to shift gears a little bit and then talk about block grants and what that means in terms of funding rural communities. And this comes from some of our work through our Rural Health Research Center. We have a study that we titled "Following the Money, Do Block Grant Resources Reach Rural Communities?" Just again to level set, when we're talking about block grants, we're talking about non-competitive formula-based grants from the federal government to states. These are typically used to fund health and social services. State and local governments like them typically based on the fact that they provide flexibility. So they do allow them to more effectively meet community needs as compared to some of those more categorical grants. But often it appears that those resources end up in more concentrated urban areas. Some of that's based on metrics. So if you've got a limited amount of money, you're going to put it where you can affect the most people, and that drives you to urban areas. But there's also a concern that as we have transitioned funding to block grants, the pie has gotten smaller. So essentially, we've consolidated a lot of categorical grants into these block grants, but the total of those categorical grants was more than the block grant became. So it's often seen as a way to actually reduce funding that goes out to communities as well. So what we did is a mixed method study. So we tried to track those dollars using document reviews and quantitative analyses. We then did interviews to gather state and local perspectives on how those monies are allocated. And we focused this across 5 block grant programs across 3 federal agencies, CDC, SAMHSA, and the Administration for Children and Families. Here are some of our key findings. And this first one to me may be the biggest takeaway, and I think it's really, really shocking. These block grant programs, for the most part, were developed in the 1970s and 80s. And as I mentioned, they were created by taking all of these categorical funding streams and squishing them together into the block grant. That may sound fine, but the formulas were based on those original historic funding levels from those categorical grant programs using population demographics from the 1970s and 80s, and they have never been updated. And I think that's really the key. So we are allocating dollar amounts to states based on what those states looked like in the 1970s and 80s, and nobody has updated that. And the reason is that it literally takes an act of Congress to change it, and nobody is asking. So if you were to change these formulas, it's a set amount of money. So you will have some winners and some losers, and somebody's going to be mad. And if nobody's asking, why make anybody mad? So I think that's a really important takeaway. If we think that these formulas don't work anymore, we need to be advocating for these formulas to be changed. I honestly don't see a lot of political will to make that happen at this point, but it takes people asking first and foremost. We do think, however, that once those monies reach the states, and this is this last bullet on the slide, once those monies reach the states, that may be the policy opportunity to work with the states to allocate those monies within their state more effectively. So again, just to kind of summarize that, it would be really nice to get a more accurate picture of how much money should go to each state. That's what's going to require congressional action. If we aren't able to do that, at the very least, we ought to be working with the states themselves to make sure that the money that they push out within their communities is allocated in a way that makes sense. So, as I mentioned, people like these block grant programs because the funds are flexible. States generally are encouraged to work with partners to draft their plans on how to maximize the utility. Often within these programs, there are populations of focus, but the funding is typically not enough to address all of the need, which again is why we think that a lot of this money goes to urban areas. And this last bullet is really important from a rural perspective. Rurality is typically not an explicit priority area or population. So even as we're thinking about populations of focus, rural is typically not within that. So here are the recommendations we came up with for this study. Consider integrating or expanding mechanisms that could support the more effective distribution of these block grants. Review the formulas if we can get that political will. Consider base and floor amounts. So we should make sure that every state's getting at least a reasonable amount to make sure that they can serve their rural communities. And we advocate very heavily for rural carve-outs. So a minimum amount should go to rural communities to make sure there's enough money to affect change in communities that we know experience a lot of health disparities. Rural providers and organizations should be connecting with their state agencies and advocating for better allocation based on rural health needs within their states. Again, we think that the advocacy opportunity is really more so at the state level for block grants. Consider opportunities to promote or include rurality in the state needs assessment to make the case for why more money should come to rural communities. And then build the capacity of rural organizations within your states to make sure that they can receive and use block grant funds effectively, particularly in states that have a competitive process. Help make sure that your communities are more competitive in receiving those funds. And if you would like more information on this study, we did publish a paper in Public Health Reports on this study. So then shifting gears again, what I want to talk about next are those area level vulnerability indices, what we refer to as ALVREs. So as I mentioned, these are a few of the studies that we've done in this area. We've done a lot of work in this area. But as I mentioned, these are some of the area level indices that we're talking about. Probably the ones that you're most familiar with are the Area Deprivation Index, which is used by CMS, and the Social Vulnerability Index, which is used by CDC. But we've identified over 50 of these, and it's kind of amazing how many of these indices are out there. Here's what I want you to know. None of these indices have ever been validated, which I think is kind of the shocking takeaway from this. And I'm gonna go into the details a little bit about how they perform, but all of these were really developed through a consensus process where smart people got in a room and said, we think that these are important measures of vulnerability or deprivation. Let's put them in an index and score counties, score communities, and see if we can use that as a way to prioritize resources to communities. Sounds good in theory, but they've not been validated. And what we're finding is they may not work as well as we think they should in most cases. So we did do some work on this for the Milbank Memorial Fund. This is one of the policy documents that we developed for Milbank, and you have the link here. I'm not going to go through all this, but these are the indices that we looked at within that study. What I do want to do is highlight a couple of these, though. So the first example is the Area Deprivation Index. As I mentioned, this is the index that's used by CMS. It was originally developed at HRSA and has been maintained at the University of Wisconsin. It's a composite measure of deprivation across 17 measures, and it has been used for all kinds of studies looking at mortality, healthcare utilization, surgery, cardiovascular health, you name it. Just to show you what this looks like, this is my state of Tennessee. So the top picture of Tennessee is the state version of the index. Bottom picture is the national version. The red are the areas that are most disadvantaged. And just as a comparison, this is a map of Tennessee, which shows your rural counties, which are the lighter blue. And you can kind of see that the lighter blue in the case of ADI corresponds fairly well to the areas that we think have more deprivation. Conversely, this is the Social Vulnerability Index. So SVI was actually developed at CDC for a very specific purpose, which was to help local officials identify communities that may need support before, during, and after disasters. So this was developed as an emergency preparedness tool, which I think a lot of people don't realize because it has been used for everything else. So I think that's another important takeaway. This is like ADI, this is also a composite measure of, in this case, vulnerability, and it looks at 16 measures across domains. And then this is what this one looks like. So the top map in this case is the county level SVI. The darker blue are the areas with high vulnerability. The bottom map is census tract level. And again, pulling up the map of Tennessee, suddenly in this tool, the rural areas look less vulnerable. So again, what you get may depend a little bit on the tool you use. And as I mentioned before, they haven't been validated to see how they perform relative to geography or any other number of factors. So what I'm showing you here is a snapshot across several of these tools. What you have on the bottom, the x-axis, are the level of rurality. So 1 is the most urban on the left, 9 is the most rural on the right. And then the level of vulnerability, as shown in that tool, is on the y-axis. And what I want you to look at, it's interesting across these, but what I want you to look at is the dotted line, which is the Social Vulnerability Index. So according to the Social Vulnerability Index, the least vulnerable communities in the United States are the ones in the 9s, the most urban and the most rural. And I think intuitively, for those of us who either work in inner city areas or in highly remote areas, that doesn't make sense. So again, I think we need to be careful in how we use these tools. Which really brings me to this. So who has used them? Federal agencies have used them, state and local health departments have used them, state Medicaid agencies, private philanthropies, healthcare organizations. We have identified use case after use case. They have been used to allocate public health infrastructure grant funding, health and human services funding. They've been used to prioritize areas for vaccinations during the pandemic, decide where we may need more clinicians or clinics, how to allocate funding to areas that have need. These have been used for all kinds of really important purposes. And if it is not allocating to the money to the areas or the resources to the areas that we think have the greatest need, that's a huge concern. So from our perspective, this is something that is very not only concerning, but actionable in terms of policy. And these are our recommendations from this work. So ask the question, is an index the right approach? Consider when you do that, the initial purpose and method of development of that index. If the index was developed to allocate emergency preparedness resources, it might not be the best tool to allocate financial resources. Think about what is the right geographic level. Some of these are organized at different levels. You saw for SVI, it's done at both the census tract and the county level. How do you operationalize the index? Consider the scale. Consider whether it should be dichotomized or kept in a continuous scale. consider the measures within the index and what else might be relevant. But just because there is a measure in the index, what we're finding is a lot of those measures really don't add predictive values. There may not be meaningful associations, so it may not really be adding. And what we think may be a better thing to do is to actually go deeper into these indices and pull out the measures of interest that you think actually are reflective of the topic and phenomena that you're trying to address, and use the direct measures themselves. Related to that, many of these do not include measures related to healthcare context. So if we're thinking about health issues, that data may not be in the tool. And then continuously monitor and evaluate your use. And if it's not doing what you think it should do, you may not want to use the index. So I think that's probably one of my favorite bodies of work that we're doing right now, just because it's kind of stunning how many examples we find of people who are using these tools and probably not getting the outcomes that they expected, and not really understanding why. So I hope this really helps to inform a lot of that policy. So this is where I want to really wrap things up. And then I'm going to have, I think, some ample time for questions, and I'm happy to have some discussions. But to me, maybe the most important thing I want to share with you are tools to find data in your community. You need to make the case for why these resources need to come to your community. And to do that, you should be doing community health assessments. And we want to be able to help you identify the data and resources that help justify the allocation of those resources. One of these is a tool that we developed, and you see the website at the bottom, ruralhealthmap.norc.org. This is the Rural Health Mapping tool. This was actually funded by CDC, and it includes all kinds of different data, but the data I'm showing you here are leading cause of death data. In this instance, this is a heat map showing heart disease mortality rates. And I've again zoomed in on my state of Tennessee. But you can see that heat map, the darker areas are the counties that have higher mortality rates. You can organize counties by only rural or urban geography. I didn't do that in this case. One of the things that I think is really cool, though, so the data are organized into quartiles. And in the national map, which you see here, every county is put into a quartile based on national data. So as you might expect, if we were to zoom out, the southern states where we know there are greater disparities tend to be darker. The other thing you can do, though, if you're working at the state level, is you can reorganize the data only by county so that the quartiles are set up as showing just within state differences. So rather than comparing Tennessee to the nation, we're comparing Tennessee to Tennessee. Provides a little bit more granularity if you have limited resources, a little bit easier to identify the counties with the highest need using these maps than comparing it to national data. So as we do with all of our tools, you can click on any county and it gives you the data for that county. So in this case, we're in Western Tennessee, looking at Crockett County, which has a heart disease mortality rate of 470.2 per 100,000. When you click on view details, you get all of the leading cause of death data compared to the state as a whole and compared to the United States. So you can see how your county is doing relative to the state and relative to the country. And then if we were to do the drop downs here, there's all kinds of other data in here related to food insecurity. There's data related to demographics. We want this, again, to be a one-stop shop that provides you with information that you can use in justifying the allocation of resources to your communities and hopefully in successfully writing proposals to bring more money into your communities. One of the other things that I think is kind of cool is that you can create overlays. So in this case, we have taken that same heart disease mortality map and we've created an overlay of health insurance coverage. So the larger pink bubbles here are the counties that have higher uninsurance rates. And you can see that there's a lot of these counties that have very high heart disease mortality rates, also have very high levels of uninsurance. Similarly, this is now looking at the percentage of the population that is food insecure. And again, you see this relationship where a lot of the counties that have the greatest disparities in heart disease also have those larger bubbles that show food insecurity. And that's just a very, very quick snapshot. There's all kinds of other data in here, also including access to healthcare data. So we want to really make sure you can access those resources easily. The other tool I did want to share is, and it looks similar, but this is an entirely different set of data. This one is our Recovery Ecosystem Index, rei.norc.org. And I'll tell you a little bit about what we think of as recovery ecosystems, but this tool has two views. And this view is actually the overdose mortality rate for every county in the United States. Not every county, it's a lot of those gray counties are actually counties where the data are suppressed because the numbers are too low, but it's data available for every county with reportable data. And again, as before, the darker blue are the higher areas of overdose mortality in the United States. Similarly, this is zooming into Tennessee, and you can see what this looks like. Central Appalachia, where we are, is it remains one of the regions in the United States with the greatest challenge related to overdose mortality. As with our other tools, you can overlay data. So in this case, we are overlaying the number of substance use provider treatment facilities per 100,000. And you can see in my state, we've got some very small bubbles in some of those dark blue counties, which is a concern. Compare that to Kentucky, which has invested heavily in substance use treatment. Kentucky has the most inpatient treatment beds of any state in the United States. You can see that in this map and just how much greater access there is to substance use treatment as compared to my state or other states around the country. And then the other view of this tool is what we refer to as the recovery ecosystem. So just to kind of tell you what we're talking about here, in the substance use and recovery space, getting people into treatment is really critical. It's job one. Again, Kentucky does a great job of that. But that's just the beginning. We need to get people access to treatment. But once they complete treatment, we need to make sure that there are community supports to help them maintain their recovery. And that's what we mean when we refer to a recovery ecosystem. So for this tool, we identified a set of measures that we think are indicative of the strength of that recovery ecosystem at the community level. I'll show you them in a bit. But again, you can see as you zoom in here, Kentucky does a really good job of this. Tennessee, not quite as much. Virginia, not quite as much. West Virginia, not quite as much. We struggle with making sure that we have those supports available for people who need them in our communities. And then, as with our other tools, you can click on a county and get the data. And these are the measures that exist within this tool. So substance use treatment facilities per capita, distance to medication-assisted treatment, mental health providers per capita, distance to syringe service programs, whether or not you have recovery meetings, whether there's a drug-free communities coalition, whether there's a drug court, social associations per 100,000 or per 10,000, and then the policy environment score. So we identified a number of state-level policies that we think are indicative of a strong recovery ecosystem. So again, we get this data for every county in the country. We want counties to use this tool to look and see where their deficits are and where they can invest to provide a better environment to help people in recovery support and maintain that recovery, hopefully to then reduce overdose mortality. That's just a couple of our tools. We have others. If anybody's interested in these or wants to know about our other tools, please reach out to me. These are tools we're really proud of, and I'm always happy to share them. And then just really to wrap things up before I take any questions, here's really what I want you to take away from this. Advocate to ensure that block grant funds reach rural communities. Caution funders against using these area level vulnerability indices as a strategy to allocate funding. Understand the limitations of rural data in decision making. I didn't talk about that a lot, but we do know that rural data, because of small numbers, we have challenges, and we need to understand some of the limitations that come with that. encourage funders to test new strategies in rural areas so that we can identify and strengthen an evidence base of what we know works to support people in our communities, and then know where to access your data to make the best case for revenue investments in your communities. And then this is how you can reach me. And again, I'm always happy to talk about these issues. And I'm just going to stop there, and I'll open it up and see if anyone has questions.
Awesome. Somebody did put in a question. They said, what sort of processes could be used to validate indices like the SVI, CRE, et cetera? What would that take?
Yeah, so we should be doing validation studies to make sure that that the measures of interest are leading to the results that we want. So, what I mean by that is if we're trying to address health disparities, we can look at the areas that have health disparities, and we can see whether these tools allocate money to those areas. If the outcome is an emergency preparedness outcome, we can look to see areas that have greater preparedness needs. Do these tools allocate resources to these areas? All of these tools were developed with really good intention. And I think there's been an assumption probably among the people who developed the tools, but certainly among the users of these tools, that they're doing things more effectively than they really are. I think in our public health space, I think that when people see that the social vulnerability index was developed by CDC, in public health, we all have tremendous respect for CDC. We know they're smart people who do really good work. We assume that it's a good tool. And most of us don't realize that it really hasn't been validated. So, I think it's doing studies like that that really tie the tools to the desired outcomes to see whether they are really allocating things in the way that we think they need to. Which I will say honestly isn't that hard to do. And I think it's more an oversight that everyone just assumed that these were doing what we expected, and nobody's really done the studies to determine that they haven't been.
Great, thank you. And I did actually go ahead and link those two tools that you had mentioned previously, the rural health
Fantastic.
mapping ones in the chat. So if anybody wants to take advantage of those, they are linked in the chat, but I can also include that in the follow-up email after this webinar. Yeah, so that is actually all the questions we had. Thank you so much for joining us today. This has been so helpful.
My pleasure, anytime.
Yeah. And just as a shout out for Patagonia Health, and if you have any questions about us or what we do, we are an integrated EHR practice management and billing solution designed specifically for public health departments, even in rural areas. So if you would like to learn about us, visit our website at www.patagoniahealth.com. And if you have any questions for Michael, I will attach his email to the follow-up webinar or follow-up email. And yeah, that would be awesome. Thank you so much, Michael.
My pleasure. Thank you all.
Great. Have a great day, everyone.